Thank you very much, Mr. Chairman. Dear colleagues, good afternoon. So during the next 15 minutes, we're going to talk about dialysis catheters. These are my conflicts of interest. And I would like to start with this question for you. What are the 3 reasons why correct management of dialysis catheters is so important? I think the 3 answers. The first one is to avoid mechanical and infectious complications. That's quite obvious. Second answer is that one of the most common causes of alarm on the CRT machines come from the catheters. Look, for example, you worked for 20 hours from very early morning, and then you go to bed around 5:30 in the morning the next day. You worked all day, you had a lot of admissions, and then would you like to be called by the nurse at 5:30 a.m. because you have an alarm on the CRT machine? Well, you can end up by killing yourself or killing the nurse, it depends. So that's to get more stability with the CRT machine, then you need a good management of the catheter. But I think the most important reason is this one, is if you have a good catheter management, then you have a stable renal replacement therapy session. And that's extremely important to decrease the gap between the prescribed dialysis dose and the real administered dose. Indeed, it's impossible to get the administered dose as exactly the same as the prescribed dose. Why is this? Because when the nurse takes care of the patient during the nursing periods, then they stop the treatment for several minutes. So you lose a little bit of dose. Then when they change the bags, the effluent bags, the dialysate bag, the substitution fluid bag, then also they stop the machine, the treatment, so you lose a little bit of dose again. And then sometimes you send the patient to the operating room, you send the patient to the CT scan, so you lose again some dialysis dose. And then if you have, in addition to all of this, circuit problems due to catheter problems, then you're going to end up with less than 20 ml per kilo per hour, which is really too low, and this is not recommended by the guidelines. So that's why actually when you target the right dose, 25 ml per kilo per hour, recommended by the KDIGO guidelines, that means that you have to prescribe more, 30 to 35 ml per kilo per hour. So then you can reach the administered dose, 25 ml per kilo per hour. So which law when it comes to dialysis catheters? This is, of course, the Hagen-Poiseuille law, which is very important to have in mind. So what is this law? This law means that the blood flow here, this is the flow allowed inside the catheter, is directly function to the diameter of your catheter, directly proportional with the diameter of the catheter, and inversely proportional to the length of the catheter. That means the higher your blood flow would be if you have short catheters. So where you should insert the catheter? Well, this is the most important slide, I think, of this talk. You should insert the catheter where you have a high blood flow rate location. And where is the best place for high blood flow rate? This is the junction between the right atrium and the superior vena cava. So how to get there? You can get there easily with a short catheter, 15 centimeters, if you place the catheter in the right internal jugular vein. So if it's not possible, then you go to the femoral vein. But be careful, on the femoral territory, you need at least a 25 centimeter catheter because you need to reach the inferior vena cava to get a high blood flow rate location. So that means for the femoral territory, there is a kind of compromise between the reach of the high blood flow rate location and the length of the catheter. So then If it's not possible also here, then you go to the left internal jugular vein. And of course, as you well know, you avoid the subclavian sites. So how did the KDIGO experts provide this ranking? Just because of studies like this, published in Clinical Medicine in 2010, they randomized more than 700 patients, and they looked at the catheter dysfunctions according to the site. And they found that, right jugular vein, femoral vein, it was associated with less catheter dysfunctions, but then with left jugular vein, there were more catheter dysfunctions. Which diameter? Again, you come back to the Poiseuille law. You have a big catheter, then the blood flow inside the catheter will be able to be high. So that means the diameter of the catheter depends on the modality you choose. If you want to give to your patient, CRT with CO2 removal, then you need a high blood flow, at least 400 to 450 ml per minute. So that means that you need a big catheter, 14 to 16 French. But if you provide, intermittent hemodialysis, you also need a big catheter because your blood flow would be around 200 to 50 ml per minute. But if you go with CVVHD, continuous hemodialysis, your blood flow doesn't need to be very high, so that means you can decrease the diameter of your catheter. What is recirculation? Recirculation is when your blood, which the clean blood here, going out from the catheter, is going again inside the catheter and going again to be cleaned a second time. I mean, do you clean your clothes when they are dirty twice? No, you clean your clothes only once. So you just need one passage into the machine, right? So you want to decrease as much as possible this phenomenon. But this phenomenon is mandatory. There is always a little bit of recirculation. But when there is recirculation, of course, the efficacy of your session is impaired. So how to decrease recirculation? The first thing is, of course, you need a distance of 2 to 3 centimeters between the proximal hole and the distal hole. The second thing is that, again, you need to place the tip of your catheter in a high blood flow rate location. So if you place the extremity of the catheter in a high blood flow rate location, you're going to decrease a lot the recirculation rate. And of course, do not reverse the lines. I'm sure here, nobody reversed the lines. But I'm just saying this because some people, not here again, but outside the room, sometimes they switch the lines. So the problem when you do this, you increase extremely a lot the recirculation rate. Sometimes you reach 50%. So you impair, your efficacy of the session is going to be really impaired. And more importantly, sometimes when you switch the line, it's because your entrance pressure is getting very, very negative. So you feel there is a problem, you switch the line, and then you think you solved the problem. But sometimes it's very negative pressure. It's due because of a small clot in the arterial line. So what's going to happen to this clot if you switch the line? Well, this clot is going to be sent to the circulation. So your patient is going to thank you for the pulmonary embolism. Okay? So this is absolutely forbidden to switch the line. When you have problem, you may need to gradually exchange the catheter or to change the site. Which design? Well, the thing is, what you have to remember is you want a laminar flux. This is very important because then with the laminar flux, you're going to decrease your risk of thrombosis. If you get turbulent flux here, then you increase your risk of thrombosis. Turbulent flux means future thrombosis. So these are the different designs you can find in terms of catheter lumens. So look, each time you have angles here, that means turbulent flux. So this is exactly what you don't want. That's why the optimized lumen, the form is this one. This is called the cycle C catheter or the kidney, kidney shape. Why is this? Because of this, this form like a kidney. So kidney shape catheters are the ones recommended today. Well, designed for the tip of the catheter. Again, here you can see you have some lateral holes. The lateral holes means turbulent flux, which means thrombosis. So you don't want to use the catheters with lateral holes. The one you want to use is called the shotgun catheter, which is the one which is recommended. Sometimes you face problem with the shotgun catheter, but you just need to move a little bit your catheter to put the right orientation. So for the extremity, shotgun catheter. Local special treatments, some people, they claim that we need to use antibiotic coating, anti-traumatic coating in order to decrease complications. While there are conflicting data in the literature, but at this time, this is clearly not recommended in clinical practice. There is a lot of technological improvement also in this field. Now we can find some kink-resistant guide wires, and I think they are really, really nice. You can do these guide wires, they always remain like this. They don't go like this, and it's much more easy to use them. So when it comes to, change the catheter, you face sometimes two possibilities. You can do guide wire exchange, or you can change the sites. What is the best? Well, in terms of infection, this is a nice study in which they match 400 patients in two cohorts of 200 patients, and they found the same amount of colonization and infection in both groups, showing that there's no difference in terms of infectious complications. But in terms of malfunction, dysfunction catheter, it is much better to switch to another site than to do a guide wire exchange. Okay? So if you have to decide between the two, now in my unit we prefer to change the site because less of future dysfunctions. Now I would like to finish because I cannot talk about catheters without showing this slide. How do you technically proceed for a guide wire exchange? Well, you have two methods, two procedures. One is very dirty, one is very clean. Of course, here I'm sure everybody does the clean procedure, but I'm just going to repeat it because I know somewhere else they do the dirty procedure. So the dirty procedure, if you have your old the catheter you want to change, and you just place the guide wire here inside the dirty catheter. Well, this is very dirty, of course, and that might lead to infectious complications. But another procedure, which could be interesting, is you ask the nurse to remove the suture straight, and you ask the nurse to clean here. Then you arrive with your sterile outfit, and you place your 3 sterile fields. With your hand, which is now contaminated, you remove a little bit the catheter, and then you have here a clean section of the catheter, correct? Then with your clean hand, you take a clamp, and then you have the clamp on the clean part of the catheter. You cut here, the clean part, but be careful, here should be at least 1 centimeter. Then you remove the dirty part of the catheter, you change your gloves, you stay clean, and then here, be very, very careful. This is a very dangerous part. So, you insert the guide wire here in the catheter. With your hand, you be very careful. You keep it. You don't want your catheter to go into the circulation. You insert your guide wire. You remove the old catheter. You place the new catheter, and then you're done. So I think this is the correct way to do. We wrote some recommendations in terms of catheter management with some friends and colleagues. I suggest you can read them. And with that, your patient is going to say thank you because the dialysis dose is going to be reached, and you are going to be able to get some sleep also during night shift. Thank you very much.
Thank you very much for this overview. Are there questions? I am personally convinced that the best catheter is supraclavicular subclavian vein from the right side. But I am the only one in this room, so then it's the shortest catheter, has no bending, has no vascular damage, has a highest blood flow rate, and has no movement if you change it.
In the subclavian site?
Pardon me?
This is what you said in the subclavian site?
Supraclavicular subclavian.
Okay. Yeah, that's
okay, but this is just a comment. In Italy, it's also very popular now. Okay, are there questions?
Thank you for this very clear talk. I have a question on the next clinical research question. What is the next clinical research question on the RRT catheter? Thank you.
Well, there is, as I said before, there is some technical progress in terms of catheters. I really like this new guide wire, which is not going to be able to get some, deformation. There is also some new catheters called the palindrome catheter. This new catheter, it's very symmetric catheter. And the people who sell this kind of catheter, they claim that there is no recirculation at all. But this is only internal data from the companies. And I would like to see some academic data, some study looking at the recirculation rate with this kind of catheters. I think what a good research question in terms of catheters would be, what is the best way to limit the recirculation? Because there's always a little bit of recirculation. Of course, the more recirculation you have, the more you decrease your efficacy in terms of treatment.
Last question. If you don't use a catheter, how to lock?
For the
locking.
Oh, yes. So in terms of lock, we use a citrate lock in order to decrease. So for the locks, it's also, you can find very conflicting data in the literature. So our experience with the citrate lock is quite convincing for me. We have no problem with the citrate locks. But we don't use very concentrated citrate lock, like only 4%.
4%?
Yeah.
4?
Yeah. Not too high, because I'm still afraid that the nurse is going to send the lock inside the patient.
Okay, are there more questions? If this is not the case, thank you very much again. And we come to the next problem.